Hello and welcome back to the Hot Pot. I'm Casey and I am today's episode host. We're honored to have Dr. Joshua Bauml joining us today. Dr. Bauml leads lung cancer development at Johnson & Johnson Innovative Medicine, where he oversees everything from mature treatments to identifying new partnerships. But what makes this conversation especially relevant is that before joining Johnson & Johnson Innovative Medicine, Dr. Bauml spent years as a practicing oncologist treating lung cancer patients. Josh, welcome to the Hot Pot.
Thanks so much for having me, Casey. It's great to be here.
First off, can you please tell us a little bit about yourself and what led you to your professional journey in advancing science and innovation for patients with lung cancer?
I became a doctor because I wanted to help people at that time when they really needed it most. And being an oncologist it's a very difficult job, but it's very rewarding as well, because at that moment, when someone is diagnosed with this horrible, horrible disease, you are in a position to really help them and their family to make this time that is so, so difficult ever so slightly easier. And it's been my absolute privilege to take care of patients throughout over many years, and see the advances that have happened in the field.
Thank you so much for sharing your story, Josh. Now, to zoom out a bit, lung cancer is the third most common cancer in the US, but it is the number one cause of death by cancer. What should our audience know about the different risk factors for lung cancer?
Lung cancer is, as you said, the leading cause of cancer death for both men and women worldwide. It is, such a horrible disease. Obviously, the things that people think about when they think about lung cancer is they think about smoking. Some people think of radon exposure, other environmental exposures. But the truth is, the only real risk factor that someone needs to develop lung cancer is having lungs. We're seeing a rising incidence of lung cancer in patients who have little or no tobacco exposure. And this is particularly prevalent within the Asian communities, both within Asian American, Pacific Islander communities, like you've mentioned, like many of your audience here, but also populations in Asia. It's not exactly clear why this is happening, but still, one of the major issues that patients with lung cancer experience is stigma,
Mhm.
where patients will say, "Oh, they have a diagnosis of lung cancer," and then immediately have to say, "Oh, but I never smoked." There's no other disease where patients feel the need to defend themselves in this way. It's really not fair. And so one of the things that we've been trying to do really hard, both when I was in clinical practice as well as now at Johnson & Johnson, is to emphasize the fact that our goal is to treat patients with lung cancer regardless of what those pre-existing conditions were, because at the end of the day, it doesn't matter. The goal is to help the patient and their family.
What you're saying about stigma just really resonates for us here at the Health Forum. Like you mentioned, there are just so many different feelings that will bubble up for community members, and especially more so for Asian American, Native Hawaiian, Pacific Islander communities, where there's additional cultural barriers or ways that they view certain diseases or just the ways that they respond to the news. Can you share any stories that you might have as it relates to, you mentioned communicating with patients and trying to combat that stigma or shame. What's something that you might be able to share with us?
It's very interesting. Culturally, every culture has a different view of how they speak about cancer. In
Yeah.
fact, there are some communities where, even to this day, they just don't use the word cancer. They'll say, "Oh, this person, they died. How'd they die? Oh, they died." There
Hmm.
was a patient who I remember very vividly who I was treating, who it was an older gentleman, and his daughter was bringing him in for treatment. And she said to me in no uncertain terms, "Do not tell my father he has lung cancer. We'll come in, we'll give him the treatment, but do not tell him." And it introduced a lot of ethical concerns. The patient's going to get treatment. How do we justify this? And we had to consult with the local ethicist and things like this. But at the end of the day, we want to be respectful of people's culture and their lived experience so that they can get the care that fits most with their wishes.
I completely agree that the emphasis really needs to be adjusting or not even adjusting, being culturally responsive to the different communities that we're serving and that we're talking to. And really appreciate you uplifting how different patients and family members, even, we need to be cognizant of the ways that they view cancer, or, like you said, not even have a name for cancer, even for
Yeah.
their own language or culture. Going back to what you had mentioned for non-smoking Asian Americans and Asians at large, you mentioned that there is not current research in terms of like we have the perfect answer as to why this is happening. But I know that a lot of your work specifically is looking into different treatments that would be responsive to different patient needs. Could you maybe shed a little insight as to what you're noticing is, might this be something that's mutationally relevant? Is this something that's genetics, environmental risks? What are the specific things that we're looking at with regards to this population?
Yeah, in patients with little or no tobacco history, the lung cancer that those persons tend to develop is very different biologically from the lung cancer in a patient who has a history of tobacco exposure. So, most notably, in patients with little or no tobacco history, they tend to have what we call a driver alteration. That's basically like a gene that's got turned on and can't turn off. And it makes the cell just keep going, keep going, keep going, and keep growing. And that creates a cancer. It's something called an oncogene. And so if you can imagine this, imagine you had a lamp, okay? And the lamp's on your shelf, and you can turn the lamp on and off with a little, pull switch. Imagine if that pull switch stopped working and the lamp is stuck on. That's what an oncogene is. You can still unplug the lamp will still turn off. And that's exactly what's happening with targeted therapy for lung cancer. So, particularly for patients in the Asian communities, the alteration that's most commonly seen is something called a EGFR, or epidermal growth factor receptor mutation. And this receptor gets what we call constitutively activated and makes cells grow. Many of the targeted therapies that have been developed for the treatment of this disease are like unplugging the lamp. They basically inhibit that EGFR pathway, and that helps to make the cancers get smaller. This is usually used in the metastatic setting, though there's now some emerging data showing about using it earlier. Unfortunately, because these cancers tend to develop in patients with little or no tobacco history, we often don't do as much screening. And so that's why patients end up presenting at later stages where unfortunately the cancer is not curable.
Thank you so much for sharing that lamp analogy. I feel like the picture is just so clear in my mind now about how all of that works when we talk
Yeah.
about a lot of the non-smoking related lung cancers, and pulling the plug from the lamp as the way that targeted therapies are doing the same thing. I suppose going into what you had just mentioned in really not knowing until the later stages that some of these patients have lung cancer, is the big answer to this then simply education, outreach, just increasing awareness for Asian American communities?
So certainly that is a valuable thing. If someone is having persistent cough or shortness of breath, definitely go and speak to your doctor. That's always a good idea. We are, however, seeing some really exciting data with the use of CT screening in certain Asian populations. There was a big study that was done in Taiwan where they demonstrated that lung cancer screening in Asian women was effective in preventing lung cancer deaths. And I know that Dr. Elaine Shum in New York is running a similar study in patient populations, trying to see if you can bring that to other areas. There's also some really cool work that's being done by many other researchers around the world, trying to see if you can utilize blood-based biomarkers or other sorts of tests to broadly test and then identify who might be at highest risk. There's a lot of people who are doing work to try to improve this field because we really have to work together. This is an awful disease, and no one person is going to be able to solve it by themselves.
Thank you for sharing all the innovation that is out there, all the different folks who are working on this issue. You mentioned Dr. Elaine Shum. I know there are also researchers and efforts going underway at UCSF as well. And we're just so grateful that larger attention is being brought to this issue. And also, at the end of the day, like you said, early screenings can have such life-changing consequences.
Yeah, I mean, the difficulty is that if you look at the National Lung Screening Trial, which was the trial that established CT screening as a way to reduce the risk of lung cancer death, part of the difficulty is that over 90% of the things that were seen on the CAT scans, and these are patients with a history of tobacco exposure, heavy tobacco exposure generally, over 90% of the things that were seen were not cancer. And
Oh,
so this is an issue where if you do CAT scans on everyone, because that's the question. So why don't we just do a CAT scan on everyone? Well, the issue is, first of all, that there's a lot of radiation
yeah.
exposure. And second of all, a lot of stuff that you'll see won't be cancer. So we need to figure out a way to adjust our intervention to the risk of the people who are undergoing that intervention. In certain populations, just to the numbers are pretty stark. So
Mhm.
if you look at the overall incidence of EGFR mutation, just to take that particular, about 30%, 20 to 30% of patients around the world who have a diagnosis of adenocarcinoma of the lung have an EGFR mutation. Okay. If you take that number and you look only at patients with no or little tobacco history, the number doubles. And
Hmm.
if you take that number again and only look at Asian persons, the number doubles again. So the numbers get to be quite high. So if a person who is an Asian woman with no tobacco history who comes in with a diagnosis of lung cancer, it's about 50, 60% likelihood that they have an EGFR mutation, which is pretty remarkable. I would also like to emphasize one other point just to make things very clear. When we talk about mutations, people tend to get worried about inheriting things and genetic things passing from mother to child or father to child. While there are some family conditions that are associated with heritable risk of lung cancer, it is not one of the diseases that's generally thought to be inherited. So these EGFR mutations exist only in the lung cancer of the person that has it.
Hmm.
It's not something that is in their genes that then gets passed on to their children. So that's an important thing for people to be aware of when they're learning about this disease.
I'm really glad that you brought that up, Josh, because one thing that I have been hearing and that I know many of us in the Asian American, Native Hawaiian, Pacific Islander community and space, one of the biggest cultural barriers for lung cancer or any kind of disease in general, one of the biggest cultural barriers is feeling like there is a family curse or something that was passed down because a family member from long ago did something bad, and then now the family is currently paying for that. And that is actually something that has come up in a couple different spaces. And so that is really, I would say, regardless if something is inherited versus not inherited, that is just one kind of cultural sticking point that I just like to uplift as well. And
Well,
so,
thanks for highlighting that. I mean, I think it's really, really important. When I used to treat patients with lung cancer, and I would tell them about these gene mutations, you could see the tension on their face, even without any sort of culture implications. They'd be like, "I have this, and this is horrible." But then they look at their children, who are often supporting them in the room, like, "Do I have to worry about my kids?" And there are, as I say, there are some heritable forms, very rare. The vast majority of these are sort of they occur in that person, and it's really unclear why. Um, just it's a thing that happens.
How is Johnson & Johnson designing educational content and utilizing digital platforms to effectively reach and empower people from different backgrounds or generations or other demographics to address all these sorts of barriers we discussed?
Yeah, thanks, Casey. I'm so glad you bring this up. I mean, it's really central to the way that Johnson and Johnson thinks about not only lung cancer care, but just care in general. We have no interest in making a drug that is not going to help the people who need it, right? So that's the whole goal. We're in a partnership with the physicians who are treating patients and the patients themselves so that we can deliver the best possible therapies. I'll give an example of the way we've approached this. So, one of the things that I heard from one of our investigators is say, well, this is amazing, the work that's been done, but I have patients who need to take these prophylactic medicines. They don't speak English.
Mhm.
They only speak this language or that language. And so we've worked with our local teams to get clear descriptions of how to use these prophylactic medicines in the languages of the patients who are taking the medicines so that they can be a advocate and participant in their care in a very real way. And so that's something that's really important to us. And we're working to continue to expand these opportunities so that everyone can participate in their care to the same extent.
That is such a powerful story and really emphasizes one of the health forum's biggest priorities here too is the language access piece and making sure when we talk about all these different issues, to the extent that we can, we make it available in the languages that our communities can understand and speak and are comfortable in really grasping. So thank you for sharing that story. Well, Josh, I think we are close to wrapping up, and I just want to make sure that we ask this one final question for you. What's the one message you want every listener, whether they have been diagnosed, have a family history, or have never even thought about lung cancer yet, to take away from our conversation today?
Well, I would just emphasize the fact that the only risk factor that people need to have to develop lung cancer is having lungs, but that there is so much research that is being done for the treatment of lung cancer. There is hope that we're trying to continue to build to make this deadly disease somewhat of a better situation for patients who are suffering from it worldwide.
Well, thank you, Josh, for being a leader and bringing that hope for all of us, and also for sharing your expertise and passion with us today. It was truly a pleasure to talk with you about lung cancer and education and awareness for Asian American, Native Hawaiian, and Pacific Islander communities.
Great. Thanks so much, Casey.
And that's a wrap on this episode of The Hot Pot. Make sure to follow the Health Forum on social media at apiahf.org. Subscribe to our YouTube channel and to sign up for our emails to stay updated on future episodes. Thank you for listening, and we'll see you next time.